Welcome to part 2 of our coverage of Chapter 15, Variant Sexual Behavior. We covered in part 1 the first few of the so-called paraphilic disorders. We're going to continue today with the remainder of that list and finish up with some information that I think you might find interesting about treatment protocols and standards coming from the American Psychiatric Association. So we're starting today with coverage of what might be, for this chapter, the most difficult disorder, which is pedophilic disorder. Anytime you talk about pedophilia, it arouses strong emotions. People have very strong feelings about the criminality of this behavior, the damage it does to people who are victimized as children, as young people, at the hands of adults. So I understand that these are difficult things to discuss. So how have psychologists, psychiatrists, clinicians, counselors been trained to think about pedophilic disorder? As with all of the pedophilic disorders, you have the same kind of language here, but in some ways you're dealing with a set of cultural norms and expectations and understandings that put us in a different mindset. With that in mind, the technical definition of pedophilic disorder is recurrent intense sexual fantasies, urges, behaviors, same language we've been dealing with all of the pedophilic disorders, but this time it involves sexual activity with prepubescent children lasting for at least 6 months. Now, notice the real specific definition here, prepubescent children. So what you're talking about is kids, generally speaking, up to the age of 13. If you look at the legal statutes across the country, you do have in some cases distinctions between children of certain ages. In other cases, it's distinctions based on the age gap. But generally speaking, there are laws, there's legislation against adults having sexual interactions with children. Where things get a little dicier is beyond that 13-year-old range. 13 and above, like 13 to 18, for example, there are different state laws determining age of consent and other similar concepts. So that's a part of why you have a definition of a pedophilic disorder that specifies prepubescent children. Like our other pedophilic disorder, or like our other paraphilic disorders, you have urges that have been acted on and engaged in. There is a specifier for significant distress and impairment, just like with the other paraphilic disorders. Now, what people out in the forensic world, so clinicians working with populations that have been adjudicated through the legal system, what they will tell you is that the distress is, in their opinion, more due to being caught and being punished than it is from the behavior itself. So this specifier is sometimes seen as controversial, and even the fact of having a disorder, labeling as a psychological disorder behavior that in our culture is seen as so abhorrent, is problematic for many people. Some of you noted in your perusal comments, at least I think you did, about how can this be used as a criminal defense. Well, it's been tried, but it's highly unlikely given the nature of some of the ways in which the state statutes and even the federal statutes are written, that such a defense would be successful. In the remaining criteria for pedophilic disorder, you have to have an individual who's at least 16 years of age, and there is a specifier for an age gap, so at least 5 years older than the child that's been the target of this sexual behavior. Why those specifiers? In part, what the clinicians here, the people designing the DSM are trying to respond to is in part the way laws are written. If you have children who are acting out sexually with each other, or you have a child who's acting out sexually and is doing so with a younger a child, but it's within their own age range, that's looked at differently psychologically than when you have a significantly older person, even a 16-year-old who is acting out sexually and behaving inappropriately in response to a child that's at least 5 years younger. So there's a difference in the way clinicians and psychologists and people in criminal justice look at same age individuals, so within that 5-year range, as opposed to when there is a significant gap with the perpetrator being older. There have been lots of theories floated as to why people engage in pedophilia. As far as looking at the research evidence, there's no one theory that really explains intense recurrent attractions to and arousal in response to children. There are some who argue that this is a cultural norm that is not universal. And there are some who argue that in some cultures, in some other contexts, it's perfectly appropriate to have adults who have sexual relationships with people who are far younger. So when you look at the anthropological data, the sociological data, you look at cross-cultural comparisons, while it is true that there are sexual interactions between adults and children in some cultural contexts, that doesn't negate the fact that in our cultural context, it's an expectation that not be done, and you can't deny the clinical outcomes for people who as children have been molested by someone with a pedophilic attraction. So I will leave it to you to do further investigation. We could spend a semester talking about the cross-cultural differences in age of sexual consent and the nature of these age disparate attractions. One of the key issues for thinking about pedophilic disorder is when you have to take into consideration that these are prepubescent children. They're younger than 13, and the assumption in our cultural context is that children of that age cannot meaningfully form consent to sexual behaviors, especially when those behaviors are initiated by adults who have power and control over them. So obviously with pedophilic disorder, you have a lot of overlaps and interactions with the criminal justice system. We have clear laws and norms, cultural and otherwise, that prohibit this kind of interaction. It's obviously a part of our cultural context that we find these behaviors to be more than just problematic, but abhorrent. So the defining of a psychological disorder sometimes is interpreted as excusing what people have done. As I mentioned earlier, pedophilic disorder is not necessarily specifically named, but in the way that statutes are written, in terms of the way defenses can be proposed, there are some specific categories of disorders that cannot be used as a quote-unquote insanity defense. And disorders like this one and antisocial personality disorder are certainly in those categories. Now, your authors in your text identify some different types of pedophilic disorder or some categories that have been found in some of the research. Now, you should understand that most of this research has been done looking at forensic populations, so populations made up of individuals who have come into contact with the criminal justice system. Some of the research is done through interviews, some of it through questionnaires. Um, a comparative minority of the studies have looked at broader populations and included some individuals who do not have interactions with the criminal justice system. But the majority of the research projects have involved incarcerated people or people who are on probation. So for the types of pedophilic disorder or categories that people fall into, your authors describe the cynical category, which are described as people who engage in their behavior without having any sort of moral prohibition against it. So they don't recognize the social norms or the social values that suggest that having sexual interactions with a child is inappropriate or wrong. So when your authors say without scruples, that's what they refer to. And in fact, they may target children who they know that they have relationships with. But as the name implies, they're cynical about it. It's something that they don't perceive to be wrong. There are some who, and this is a category that is sometimes described as serial sex offending. Your authors describe them as expert. These are people who carefully groom their victims. They have multiple victims. They may have victims that are known to them and victims that are not known to them. They will often go to great lengths to find children to abuse and to have sexual interactions with. The attention-focused version of pedophilic disorder appear to be people who have a need and their attraction is oriented toward children, but their goal is to form what they see as a mutually loving relationship. In some ways, this is described by researchers as they play a love game of being somewhat interacting with a child as a buddy, as a friend, but also then as a love object. At the end of the day, though, what is being sought is sex with that child. In some ways, researchers have described this as the perpetrator is behaving as if they are in a loving relationship, but what their real goal is to have sex with a child. And then finally, there are people who have pedophilic disorder who are almost entirely sex focused. So they don't take the time to groom, they don't take the time to control, they create a situation and the immediate goal is to have sex of some kind. So these are often, stranger interactions, and they're often crimes of opportunity. Treatment of pedophilic disorder is difficult. When you look at the research literature, it's difficult, number one, to define what's success when you're treating pedophilic disorder. It's often defined in terms of recidivism rates. And as I've found, trying to update my information, my knowledge in preparation for this chapter, that there's actual controversy about how are you going to define recidivism in this context. Are you going to define it strictly in terms of whether someone is reconvicted? Is it in terms of rearrest? Is it in terms of probation and parole violations? Or is it in terms of desire and goal-driven behavior? So there's very little agreement on how success should be defined here in terms of treatment. Your authors describe a number of possible modes of treatment. Some of them are medical or biological, and others are psychological, involving various forms of psychotherapy. Cognitive behavioral treatment is often mentioned at the top of the list of psychological approaches that has been found to have moderate levels of success. In general, what's involved, and this is the very, very short version of a description, but in general, what people are taught to do is to identify the thoughts that they have that are associated with their desire to have sexual interactions with children, to identify those thoughts, confront them, replace them with other thoughts that don't involve sexual obsession with children. Cognitive therapies often involve an in-depth kind of exploration of cognitive distortions. For instance, someone with pedophilic disorder may believe that children actually get sexual satisfaction and enjoy their interactions with them. That's a cognitive distortion. So what the person in therapy would need to do is to recognize that those beliefs are false, and then learn the alternative, that in fact they are hurting, frightening, and damaging behaviors for the other person. This can also involve what's called empathy training, which is to teach people to see the impacts potentially of their behaviors from the other person's point of view. I mentioned earlier that there are medical approaches to therapy that have been tried in response to pedophilic disorder. Frequently, these are treatments that are used in conjunction with psychotherapy, and I'll discuss a little bit later some of these medications, so I'm not going to touch on that right now. It's difficult, as I mentioned before, to determine how effective these treatment approaches are. You may be able in some cases to demonstrate that certain modalities of treatment, both medical and psychotherapeutic, can reduce the actual behaviors. What you can't really measure well is the degree to which any treatment approaches modify the sexual fantasies that people may have, the sexual thoughts, the level of sexual arousal that people have when they think about children. Those aspects can be very difficult to change. So, for example, if your goal treatment-wise is to simply reduce the amount of sexual acting out and committing pedophilic acts on children, so if your goal is to reduce the behavior, you may be able to show that you've reduced that rate. At the same time, that same person who is no longer engaging in pedophilic behavior may still have very deep-seated fantasy beliefs and urges that are difficult to quantify. Now, the next disorder for us to discuss is one that students often find themselves confused about, and they often find it difficult to separate what is a disorder that involves a fetish as opposed to simply having a fetish. So we'll have to do kind of what we had to do in part 1 of this chapter, which is to try and see clearly, or at least as clearly as we can, where that line is between disordered behavior and adaptive behavior. So with fetishistic disorder, what you have is recurrent, intense, sexually arousing fantasies, urges, behaviors that involve non-living objects. Some of the more common items for males are things like female underwear, lingerie, and shoes. Those are fairly commonly reported on surveys of people who have fetishistic disorder. In other cases, it can be highly specific, emphasis on a particular but not sexual body part. For instance, feet is often at the fairly high on the list. Some people are very focused intensely on, say, hands, or I even saw an interview with someone for whom it was knees. So the idea of intense, arousing quality that's become attached to a non-living object, whether it's physical objects or parts of the body, is something that's well known in just both in popular culture, but it's also well known in the clinical and medical literature. In fetishistic disorder, the fantasies, the urges, the actions, for it to qualify as a disorder, it has to be maladaptive. And what that means, as you're pretty familiar now, is there has to be distress and there has to be impairment in terms of people's actual functioning in their daily lives. Fetish objects, there is a specifier here so that it separates out a disorder that we're going to talk about in a minute called transvestic disorder, where there's a specifier that says the objects aren't articles of clothing that are used in cross-dressing. And it'll become clear when we go over that disorder why they're making that specification here. There's also a specifier that it's not fetishistic disorder if the arousal object is intended to cause sexual arousal, such as a toy or a vibrator. As with all of the other paraphilic disorders that we've looked at so far, research hasn't really shown conclusively a cause. There have been behavioral theories that seem to make a lot of logical sense, and in some cases there has been research that at least anecdotally lends support to this argument. And the behavioral approach is fairly straightforward, that objects, either physical objects like shoes or undergarments, may have been present at a time when a person became strongly sexually aroused, and that object becomes classically conditioned as a trigger for that arousal. So when I write here, an object may become associated with a particularly powerful form of arousal or gratification, the mechanism there that's being described is pretty straightforward classical conditioning. So just like with Pavlov's dogs, the fact of the shoes being present at a moment when the person is really strongly and powerfully aroused, the arousal may have been due to actual sexual stimulation or more direct forms of sexual imagery. The shoes become associated with that and become kind of a trigger. So signaling an arousal state is to come soon. Support for that theory is moderate. It's difficult to find real hard experimental evidence to suggest one theory over another, however. Transvestic disorder, and many of you in perusal were really struggling with this. The idea of cross-dressing and trans people as a separate category. I mean, most people who cross-dress, even those who do so professionally, such as drag queens, most of those individuals are not trans. But we can talk about a couple of different categories where in our current cultural context, you may have come into your awareness the idea of cross-dressing. And some of you were asking the legitimate question, should we really be pathologizing this? I mean, RuPaul's Drag Race is a massive cultural hit. So why is cross-dressing a disorder? Well, cross-dressing per se is not a disorder. Transvestic disorder is very specifically designed. And the way it's described is you have cross-dressing or dressing in clothes of the opposite gender in order to become sexually aroused. So in this case, transvestic disorder is a very specific form of fetishistic disorder where the act of dressing against your gender role norm is sexually arousing. So the classic example, because most people who are categorized in this with this disorder are heterosexual men, so heterosexual males who dress in female clothing and sometimes role play in those clothes in order to become sexually aroused. And they may in fact find it very difficult to perform sexually when they are not dressed as women. Now, it's not unheard of for females to dress as males in order to become sexually aroused, but the number of cases is more prevalent for males. There's the specifier for 6 months of time, psychological distress, and interference with adaptive functioning. So the way you should think about this is the classic case would be a man who has found it extremely difficult to become aroused without the addition of female clothing and perhaps even female role activity in his interactions with his sexual partners. Now, that can cause disturbance. Let's say that this is a man who sees himself as very masculine in his everyday life, but in terms of his sexual functioning, he feels like he needs to manifest as a female. That could be very troubling, very disruptive, very disturbing. Now, in some of the literature here, one of the things that clinicians would have to do is to rule out gender identity issues and also take into consideration sexual orientation as well. There's cross-dressing as a global kind of behavior. It is in many ways divorced from both gender role orientation or gender identity as well as sexual orientation. It may occur, it may not. When we're talking about transvestic disorder, however, you really need to focus your attention on the fact that the cross-dressing itself is used as a tool to engage in sexual activity. So people find that they are dependent on the cross-dressing itself for sexual arousal. Like the other paraphilic disorders, you have intense sexually arousing fantasies, urges, behaviors, and the theme of those fantasies and urges and actions involve dressing as the opposite sex, and in some cases in passing as the opposite sex, but that's not required. So I wanted to be clear, cross-dressing in and of itself is not a disorder. And many of you reported, in perusal that you were confused by that, or you disagreed with the idea that cross-dressing was an illness. You would not be alone in that criticism, even though the diagnostic criteria really specify that cross-dressing in and of itself is not a disorder, that you have to have distress, you have to have kind of compulsive fantasies and urges, and that being sexually aroused is kind of limited to the sphere of being cross-dressed. There are still critics who argue that this disorder and some of the others, particularly fetishistic disorder, simply don't belong in the DSM. While they may be atypical behaviors, they may not be consistent with normative expectations, there's not anything disordered about it. Now, professionals may come back at that criticism and say, if I have a person whose marriage has blown up, who is found out at work, who's lost his job, who is distressed by his own behavior, who wants to have meaningful sexual interactions that don't involve transvestic behavior, what am I to say? You don't have a disorder, go away. So you need to kind of put yourself in the mind of what does the clinician do when they have a person in their midst who is in distress and wants to try and change his or her behavior. One of the things that research has found is that cross-dressing, and I'll qualify this. Researchers have been kind of limited in the way they've been able to explore these questions. But cross-dressing is most common in men, but it has been found in both males and females. Part of what's going on here is that it's socially more acceptable for females in our culture to dress in masculine styles. It's much less socially acceptable for males to dress in more characteristically feminine styles. So, for example, females in American culture routinely wear pants and button-down shirts and blazers and hoodies and ball caps. So it's perfectly seen as perfectly appropriate and not gender and not to be a gender mismatch if females dress, especially young people, dress in ways that are neutral. For males, however, if they were to wear skirts and makeup and nail polish and things like that, more questions arise more quickly for men. Even though the standards, the restrictions have loosened quite a lot in the last 20 years, there still is a double standard there that cross-dressing and dressing in ways that are atypical is more restrictively controlled for males than it is for females. So when you read a finding like this, where researchers have determined cross-dressing is more common in men, or that transvestic disorder is more common in men, you need to put it into appropriate cultural context before you draw conclusions. Like our other paraphilic disorders, there isn't a clear cause that's been determined. Some have argued that the learning theory, the classical conditioning theory, is possibly involved. There could have been early childhood experiences of play or dress-up play that involved accidental sexual arousal that gives rise to a connection being made in mind between the clothing, the dressing, and sexual satisfaction. It has been observed in some research that the cross-dressing may be exciting, it may be fun, it may be entertaining, and after puberty, when there's often just sort of spontaneous sexual arousal that needs to be interpreted, it may be reinterpreted as sexual excitement. On sexual addiction, and again, many of you in your perusal comments were asking questions about whether sex could be considered, whether sexual behavior could be considered a possible addictive pattern. What we run into here is a lot of debate and controversy about how the word addiction is defined. It's one of those things where if you went to a professional conference on addiction, that arguments break out during the chat hour, and people aren't rarely satisfied with the conclusion of those arguments. So in some circles, and you'll find treatment programs all over the country for sexual addiction. You will find people who talk about themselves as sexual addicts. So the use of the term sexual addiction is very common in popular culture. It's far less agreed upon in the medical literature and in the psychological and psychiatric literatures. In some cases, sexual addiction is described as a compulsive cycle of ritualized sexual behavior that's then coupled with despair and guilt and contrition. Now, as I said, use of the word addiction in the context of sexual behavior is very controversial. If you look at the most used definition of addiction, which comes from the American Society of Addiction Medicine, it's mentioned by your text authors. They talk about, and you have to break this definition down into its component parts. You have a treatable chronic medical disease involving complex interactions among brain circuits, genetics, environment, and life experiences. So the first part of the definition here has some important parts to it. You have a chronic medical disease. So in this case, if you're talking about addiction medicine specialists, they are typically MDs or DOs. They may be psychiatrists as their specialty. So they're defining addiction in very strictly medical terms, and they're using what's called the disease model of addiction. They're assuming that there's a complex set of causes, brain function, genetics, environment, and personal life experiences. The next part of the definition involves just is a descriptive of the behaviors. People with addictions use substances or engage in behaviors that become compulsive and continue despite having negative consequences. Now, the part that I put in bold there, use substances or engage in behaviors, it's the engage in behaviors clause that is relatively more recent. And that's the part that some argue leaves the door open for including compulsive sex, or what's sometimes referred to as hypersexuality, in this definition of addiction. Others go back to this idea of a chronic medical disease and feel uncomfortable with including sexual behaviors, gambling behaviors, and a handful of other kinds of patterns of behaviors that in recent years have been described as addictions in this category. Some people are very... Sorry about that little dog barking interlude. Some people are very restrictive to looking at chemical substances, so alcohol, drugs, cigarettes, even caffeine, something you take in. It has a physiological transformative effect on the way the brain and the body work. It has an addictive effect on the brain, requiring more and more of it, or when it's stopped, there's an experience of withdrawal. So some people are very strict about that. Others are less restrictive, or they think about sex as a whole body experience, and they argue that just like taking a drug or drinking alcohol, sex changes the brain. It has a powerful motivational and physiological effect on people. So there's no one answer to this. You know, I've had students ask me over the years, is sex addiction really a thing? Or isn't it just people using that as an excuse for cheating? Well, it really just depends on how you choose to define addiction. You know, there's no one definition. Now, the American Society of Addiction Medicine, their definition tends to hold the day, but that's not always going to be the case. The DSM is, as we've already been discussing in this chapter, the Diagnostic and Statistical Manual is the thing that clinicians, doctors, counselors, psychiatrists are going to use to define or to put a label on clusters of behaviors. During the run-up to the DSM-5, there was a proposal for something called hypersexual disorder, which encapsulates some of what's described in popular culture as sexual addiction. It was not included. There was a lot of debate and discussion and disagreement over not just the addiction question, so the use of the word addiction or characterizing hypersexual disorder as an addiction. There was also dispute as to the nature of the characterization of hypersexuality in the first place. Now, the International Classification of Diseases document, the ICD-11, which is sort of a more international version of not just mental disorders, but also medical disorders as well. The ICD-11 does include something called compulsive sexual behavior. It is not, however, included as a paraphilic disorder. It is instead put in the grouping with impulse control disorders, such as antisocial personality disorder would be in the DSM. So it's included in a different context, in a different position within the ICD. Its description has much to overlap with what was proposed as hypersexual disorder and what is described in popular culture as sexual addiction. So how does the ICD-11 define this concept of compulsive sexual behavior? And I'm including this for you because in the coming years, it's expected that the United States will move to adopting the ICD as the model for diagnostic processes in our medical system. I don't know whether that will come to pass, but it is something that is predicted. So how have the writers of the ICD defined compulsive sexual behavior disorder? So in this document, it's called the International Statistical Classification of Diseases and Related Health Problems. They define compulsive sexual behavior as a persistent pattern of failure to control, and that's what defines it as an impulse control disorder, failure to control intense repetitive sexual impulses or urges, which results in repetitive sexual behavior. They include symptoms like sexual activities becoming the central feature of the person's life and even the person's identity. And that causes negative effects in terms of adaptive functioning, neglecting health, neglecting personal care, putting oneself at risk, neglecting other interests and activities, and letting go of responsibilities. The person is described as having made many attempts at stopping or reducing their repetitive sexual behaviors. They continue to repeat the behaviors despite having negative outcomes as a result of them. They do have the same kind of expectation in terms of the length of time the person has been struggling. It needs to have been for at least 6 months. There's also the same kind of standard that we have in the DSM-5, paraphilic disorders, causing marked distress, significant impairment. So that's a point of agreement. The distress is described in the ICD as not being restricted to moral judgments or cultural standards. So that's not enough. You know, a person who comes in and says, you know, people think I have sex too much, or people think I'm overly sexual. I don't feel uncomfortable with my level of sexual activity, but other people do. That's not enough to result in a person being diagnosed with this compulsive sexual behavior disorder, according to the ICD. Now, I wanted to show you this, you know, in part just to show you the evolving, emerging nature of some of these classifications of disorders. And remember that part of the goal here is not to pigeonhole people's sexual behaviors, but to ensure that they can get help when they ask for it and when they need it. Now, your authors describe a researcher named Carnes, who's well known in this area and believes that there is something addictive, or at least potentially addictive, about sexual behavior in some people. So Carnes has criteria that are used to assess sexual addiction, and they're described in your text. So when Carnes describes these patterns, he looks at the fact that some people feel that they lose control over their ability to moderate their own behavior. They describe their sexual behaviors as compulsive. They have made efforts to stop repeatedly. They've lost time, meaning they spend time that they could have been using more productively and instead using it to engage in sexual behavior. They report being obsessive or preoccupied. They report that their ability to meet their obligations and responsibilities is interfered with. They report that they have negative consequences, and despite those, they continue to engage in the behavior. They often report that their behavior has become worse over time, that they're taking more risks, they're engaging in more intense behaviors. They've also experienced losses. loss of important relationships, loss of jobs, loss of opportunities, and so on. And they also tend to report that when they are able to control their behavior, that they miss it, that it's painful, that they feel irritable, that they feel disturbed by the fact that they can't engage in the behavior. Now for Carnes, he looked at this list and says, could you substitute alcohol for sex and not have the same list? And he argues you would have the same list. He argues that these are all characteristic of addictive patterns of behavior, and that regardless of whether it's alcohol, cocaine, or sex, you have the same pattern, and therefore, if it quacks like a duck and walks like a duck, it's a duck. So he looks at it here and says, if it looks like an addiction and sounds like an addiction, it's an addiction. And some of you mentioned that in perusal, that was, how could you not describe that pattern of behavior as addictive? Well, you're right, and there is the same debate going on in the medical community and in the psychological and psychiatric communities as well. Now, your authors explore a number of theoretical perspectives trying to explain the origin of the various paraphilias or paraphilic disorders. I'm not going to spend a lot of time on these. Your authors give you a perfectly good summary of them. We have a long psychoanalytic history in psychology of explanations of sexual behaviors that are considered to be deviant. Sorry, there go the dogs again. Freud speculated that problems within, particularly the phallic stage of development, failures in the Oedipal crisis could lead to sexual disturbances that could manifest as paraphilias. He also suggested, though, that earlier stages of development, even stemming back as far as infancy, could be the origin point of various paraphilic attractions, particularly things like fetishes. But then again, Freud also included homosexuality as a part of that mosaic of things that need to be explained. Now, feminist theories take a different approach. They tend to be a bit more focused on cultural norms and expectations, specifically gender role expectations. There's a tendency within feminist theory to look at the ways in which people who are not heterosexual and male, how their behavior tends to be pathologized. In learning theory, I've already mentioned there are lots of behavioral theories for how objects that are not considered normative can become associated with the sexual arousal system and with sexual gratification itself, and then be substituted for quote-unquote normal arousal triggers. And then finally, there are biological theories. There are theories that have been put out there about genetic predispositions, about hormonal differences, brain function and brain structure differences. To date, that research is still not 100%, not even close to 100% conclusive, because we don't have a lot of good evidence one way or the other to help us to understand particularly some of the thornier paraphilic disorders such as pedophilic disorder. Now, treatment approaches are similarly broad. There are lots of treatments that have been applied, but once you hone that down to what's actually used, the types of treatments that are actually used are pretty limited. And we suffer from a good amount of difficulty in determining effectiveness. Part of the problem here is that a lot of people's entry point into treatment for paraphilic disorders is through the criminal justice system. So it's a well-known kind of idea that therapy is effective, treatment is effective when you have a willing participant. If you've been court-ordered into treatment, the effectiveness of that treatment is going to be kind of impaired by the unwillingness of the participant. So since we have the typical entry into therapy through the criminal justice system, there may be interference with the ability to determine whether a particular treatment approach is effective or not. Now, some people do seek treatment voluntarily, and if you restrict your samples to those individuals, the level of effectiveness is moderate. And in some studies, not all, but in some studies is on par with treatment of other kinds of psychological problems. Now, as your authors put it, some treatment models do focus on decreasing quote-unquote deviant arousal. And a lot of this research comes from treatment specifically of pedophilic disorders. So that's part of why the language is written the way it is here. So if you are treating someone with pedophilic disorder, so they have an arousal to prepubescent children, the focus of the therapeutic intervention would be decreasing that arousal. So in some way through the therapeutic work, decreasing the degree to which that person becomes sexually aroused when they think about children, when they look at images of children, when they look at actual children, and therefore decreasing the behaviors that are associated with that, simultaneously increasing sexual arousal to appropriate targets or not prepubescent children targets. Other aspects of these treatment programs may involve social skills training, addressing faulty beliefs such as the idea that children like being touched sexually and that they enjoy the attention, looking at other sexual dysfunctions. So for example, if someone has had erectile dysfunction in response to adult women but has become sexually aroused in the presence of children, resolving that erectile dysfunction in the presence of adult images would be a part of the therapeutic approach. Dealing with co-occurring abuse, substance abuse or addiction, and other psychological problems. Typically, it's a treatment modality approach that involves multiple forms of treatment. Often, and this again, most of this research is on treatment for pedophilic disorders. Some of these approaches involve both biological and psychological modes. So there may be medications, some of which are designed to modify the hormonal system to reduce arousal generally. Some of it may involve psychological models, including cognitive behavioral therapy, empathy training, and social skills training. Some of the specific psychological models used, as I mentioned before, cognitive behavioral therapy. There's also something called relapse prevention therapy, which is something that stems from the addiction literature but has been modified to help people maintain a course where they are engaging in and expressing normative sexual arousal and attraction. And there's also the use of psychodynamic therapy. Now, as I mentioned at the outset, I wanted to finish up by kind of looking at what are some of the treatment recommendations. I won't call these best practices models, but these are treatment recommendations for pedophilic disorders. Again, a lot of the research focuses on pedophilic disorder as it's identified in forensic populations. Now, some of these treatment recommendations are also made for the other paraphilic disorders as well. But that finding that, a good portion of this population has its entry into treatment through the criminal justice system, you're dealing with a similar kind of population. So what kind of medical treatments are typically recommended for paraphilic disorders generally? Well, what's been recommended by the American Psychiatric Association, you have a class of medications called SSRIs, And why SSRIs? Because you would be right in saying that's a class of drugs that is described as an antidepressant. And in the case of drugs like Zoloft and Paxil, an anxiolytic, why would an antidepressant be useful? People aren't engaging in paraphilic disorders because they're depressed. You would be correct there. But one of the things that SSRIs have been found to be effective in doing is reducing obsessive, preoccupied thoughts. So for some people, they find it very beneficial to take SSRIs because it reduces their obsessive preoccupation with the object of their sexual arousal that they experience distress in response to. So there's also a finding with some of the SSRIs that they decrease libido, that they decrease sex drive. So if a person is simultaneously hypersexual but also paraphilic in some way, that reduction in the baseline sex drive can be helpful. It makes it possible for greater success, greater progress within therapy generally. The second category of medications are called synthetic steroidal analogs. One example is MPA. What these do is it increases catabolism of testosterone in the liver. It can suppress hypothalamic pituitary, the function of that hypothalamic pituitary gonadal axis. And basically it decreases the impact of androgens physiologically. What that's been found to do is to suppress sex drive and sexual responsiveness. So what's been reported is that that may have an effect in terms of reducing the intensity of sexual urges in people who are not just hypersexual but also paraphilic in their behavior. And then finally you have GnRH analogs. What these do is they have their impact on luteinizing hormone, and this is the hormone that is responsible for telling the testes to produce testosterone. This has been found to do in some cases, in some research, is to reduce fantasies but also paraphilic behaviors and motivational drive toward those behaviors. So there are these various classes of behaviors. Some of you mentioned in perusal the concept of chemical castration. The second one, the synthetic steroidal analogs, that's probably what you're thinking about, is the use of medications of various kinds that interfere with or suppress the effects of androgens. In some case that involves using progesterones, although that's not typical now because there are so many very, very negative medical side effects of doing so. But for some sex offenders, for example, it's a stipulation of their parole or their probation that they be on an androgen suppressant drug of some kind. Now, the American Psychiatric Association also has what they call a treatment algorithm. And basically, this is a set of decision-making guides for treatment providers before they decide what kind of treatment approach to take, be it a psychological therapy or a medical therapy. So what they have suggested, and I found this interesting, they have suggested that you divide this up into levels. And I found that, well, I'm sure that there are many criticisms and questions that you could ask as a sex researcher or as a person who provides treatment for paraphilic disorders. There are lots of questions, but I found it instructive the way in which the American Psychiatric Association has created this level system. I found that interesting and worthy of kind of thinking through. So they start with level 1, paraphilias that do not affect conventional sexual activity, but they're still distressing to the person. They're still a concern to the person. What's recommended there is straightforward psychotherapy. So you have a person who is disturbed by their behavior, they're distressed by their behavior, and perhaps it's interfering with their functioning in other domains of their lives. That's level 1. Level 2, you have what the APA describes as mild cases of hands-off paraphilic disorders with low risk of sexual violence. That could be anything from transvestic patterns to a shoe fetish, whatever. In that case, you have a person who may come to the clinical setting and be preoccupied, obsessed, feeling compelled to engage in behaviors, but feeling distressed by it, disturbed by it, troubled by it. In that case, the recommendation is a medication that would assist in reducing those obsessive or compulsive thoughts that are associated with those patterns of behavior. Now, I find it interesting that they're not recommending psychotherapy such as cognitive and behavioral therapy in that case as well, because if you think about it in terms of the logic of other kinds of disorders that involve obsessive thinking and compulsive patterns of behavior, it would make sense to include that. At level 3, and notice they're using hands-off versus hands-on, and what they're delineating there is, has your sexual paraphilic pattern, has it imposed on other persons? So the hands-on paraphilic disorders that involve fondling but don't involve sexual penetration. And here what the APA is trying to build in is connections to what we define as sexually assaultive behaviors, and with all the gradations in the criminal justice system. So you have hands-on paraphilic disorders with fondling but no penetration, paraphilic sexual fantasies but no sexual sadism. So what they're trying to communicate there is, here you have people who are touching inappropriately. So say frauderists who sneak up behind people and touch them in a sexual way without their willingness. Whereas at level 2, you may have someone who is a voyeur who feels compelled and is obsessed with thoughts of watching other people get undressed. So that's level 2 versus level 1, where you're a frauderist and you're sliding up to people and you're grabbing them by the breasts or grabbing them by the genitals. In that case, what the APA is recommending is that you may need to add to the SSRI, which helps with the obsessive and compulsive thoughts, you may need to add some way of interfering with or interrupting the arousal system. So the adding of a low dose anti-androgen. Now at level 4, moderate and high risk sexual violence without sadistic patterns. So you may have people who are compelled to force others to have sexual interactions with them, but they don't use overtly sadistic means, such as tying people up or hitting them or cutting them or burning them. So that's level 4. In that case, they're recommending more stringent steroidal approaches, where you have full dosage anti-androgen medications. Level 5 is where you have a very high risk of sexual violence that includes severe expressions, including potentially sadistic behaviors. And there, the recommendation is for long-acting GnRH drugs, which can have a long-standing impact. And then level 6 is the worst of the worst cases. They describe them here as catastrophic. So that could include people who are serial offenders, who are either very prolific, meaning they brutalize many people, and it may include people who, in addition to their sexual deviancy, are also committing violent assaults and injuring people and or murdering them. Now, what I find interesting here is not so much the recommendation side, because you can have lots of arguments about what's best in a treatment approach. Their recommendations are based on how do we prevent these individuals from doing what they're doing again. So they're really strictly looking at a prevention approach. How do we make these people less likely to engage in these behaviors going forward? At levels 1 and 2, I see them as qualitatively distinct from levels 3, 4, 5, and 6. Even 3 and 4 seem to me to be qualitatively distinct from 5 and 6. So I wanted to put that out there for you to kind of think about how would we, since these are often behaviors that come to the attention of clinicians, whether they're psychiatrists, medical doctors, psychologists, or counselors, these are people who come to them through the criminal justice system because they've broken laws. So let's say at level 2 you have a person who's been caught as a voyeur and has been exhibiting voyeuristic behavior repeatedly, has been caught, has been charged with a crime, and now has been ordered by the court into treatment. What approaches can help this person to stop that behavior so that they will not get arrested again and face jail time? At levels 3 and 4, you may have somebody, say, who just repeatedly touches other people, rubs up against them, perhaps in an aroused state, and touches them inappropriately, makes them uncomfortable. They've gotten arrested, say, on the subway for doing this repeatedly. Or you have a person who has been charged with sexual assault or rape. It doesn't have sadistic elements to it. You haven't abducted someone or tied them up and stabbed them, but you have forced them to have sexual interaction with you. So again, the question becomes, how do you make it more likely that this person will be able to stop that behavior and not reoffend? Same with the 5 and 6 cases. These are people who would have been arrested for rape and molestation, often with attendant elements of brutality and injuries, and then level 6 with potentially murders. So I just wanted you to see kind of how we can think about this interaction between the paraphilic disorders and the criminal justice system, because ultimately the question becomes, these are individuals who are likely to come out of their sentences. Regardless of the length of time they are involved with the criminal justice system, the chances are pretty good they are going to be out in the community unsupervised at some point. So the question for clinicians is, how do we reduce the likelihood that these individuals reoffend? And that's the purpose of these kinds of recommendations. All right, that concludes my coverage of this chapter. I'll see you the next time.